First of all, thank you very much. I feel truly humbled and honored to be here today. I'm probably the only emergency physician, I say, for one, or maybe two in the room. And yet my passions align with yours, my interests align with yours a lot, and a huge thank you to Rupert for inviting me to speak today. So I'm going to be talking around rapid agitation control in the emergency department. How did we arrive here and what does the future hold? So first of all, I have no financial conflicts to disclose. I receive research funding from these three bodies. I'd like to acknowledge that I work, live, play, and was fortunate to conduct the research on the traditional unceded territories of the Coast Salish peoples in British Columbia, specifically the Squamish, Tsleil-Waututh, and Musqueam peoples. And I'd also like to reach out and thank the incredible nurses and physicians at my hospital, the pharmacy department, research volunteers, and staff at Chaos who made this study possible. And of course, my family who made this feasible, tolerating a lot of text messages and calls at random hours from research assistants so that we were able to pull this study off. So I think a key thing before we proceed is that we need to touch on a definition. We're talking about severe agitation. We are not talking about excited delirium. For those of you that are APA members, you know that there's been a call for this removal of this term from the literature. It's poorly defined. It has no consistent definition or scientific validation. So we're talking about severe agitation. Now, this will become important in a few minutes. So whenever we have these patients present to our emergency department, I try and impress upon our learners the concept of the iceberg. 90 to 95% of these patients are presenting with severe substance use or mental health challenges. However, it's the danger that lurks beneath that puts them at risk and puts us at risk. It's the undifferentiated trauma, the sepsis, the stab wound, the axilla. And depending on which data set you believe, up to 1 to 4% of these patients require a critical care admission. Our data says about 1%. Some of the European data sets I've seen say up to 4%, which is astounding when you think about it. These are patients that are presenting de novo from the street or their home with paramedics and possibly police, severely agitated. So it's important for us to be able to gain rapid control and be able to properly assess them so that we don't miss the so-called pathology. So how did we arrive here? Well, all of you know this lovely molecule. It's great for sedation, it provides amnesia, but it also produces respiratory depression. And in the emergency setting, it's frequently studied with antipsychotics. There are a few studies with benzodiazepines alone, but you'll see why this is important in a minute. And haloperidol. This is what I trained with in terms of sedation control. I know some people use droperidol. Unfortunately, we don't have access to that in Canada. All sorts of issues around that. There are a few other things, and we'll touch on those in a minute. As you know, with antipsychotics, they provide sedation. They may treat an underlying psychotic disorder, which may be the cause of the presentation, but they can also put patients at risk of things like dystonia and NMS. And in our context, in the eMERGE, they're frequently studied with benzos, but there are a few studies with them alone. So this has sort of been the traditional armamentarium of most emergency physicians for the last 30 to 40 years, is benzodiazepines alone or benzodiazepines in conjunction with antipsychotics. So I'd be remiss to say that being at Oxford, ketamine is not part of my DNA as an emergency physician. We literally use it on a daily basis for pretty much everything else. Reduction of dislocated shoulders, reductions of mangled wrists, draining painful abscesses. So we're very, very comfortable with ketamine in that context. And one of my collaborators and mentors on this trial, Gary Andolfato, is a guy who did a lot of pioneering work looking at ketamine alone or in conjunction with other agents for procedural sedation in the emergency department. And so we bandied about this idea in conjunction with a couple of our psychiatrists who deal with this highly marginalized patient population and said, this makes a lot of sense. So since 1992, there have been 9 ED-based randomized trials looking at these medications, either alone, antipsychotics alone, benzodiazepines or in combination, and this is what's been studied. So you can see, there's a moderate body of evidence, but from your own experience taking care of patients in psychiatric settings, there's a significant limitation here, and that's the limitation. The best data says 10 minutes. The reality is, I've never seen a patient sedated with antipsychotics and benzodiazepines in 10 minutes. It's more like 15 to 20 to 25 minutes. And they're in restraints, they're thrashing, they're at risk of hurting themselves, they're at risk of hurting our nurses, our security staff. You can't get labs, you can't assess them. And part of my interest for this study was spawned from a couple of cases that we had that were reviewed as M&Ms. They weren't my direct cases, where patients received dose after dose after dose after dose of sedation, benzodiazepines and antipsychotics. They were still bucking, they were still thrashing, and they ended up having things like meningitis and MRSA bacteremia that went undetected for 12, 24, 36 hours because we couldn't properly assess them. So we all know and love ketamine at this conference. A little bit of history: Calvin Stevens at Wayne State first developed it, received FDA approval in 1970. And for those of you in sort of a bit of a historical frame of mind, it was first really used clinically for American GIs during the Vietnam conflict. So why ketamine? Well, as we all know, it provides dissociative anesthesia. It also acts on your opioid receptors. Why is this good? Well, once you get someone who's thrashing and needs to be restrained, it provides some analgesia, so you can get your IVs. So you can put them in restraints which are not particularly comfortable. That's a good thing. It also preserves cardiac output. It preserves your respiratory drive. I don't want to have to intubate someone after I've put a bunch of sedation into them. No one does. It has great intramuscular bioavailability, and it has a fairly predictable duration of action through the intramuscular route. Now, anecdotally, I've seen much shorter duration of action in our patients with severe substance use disorders, but it's probably in the neighborhood of 20 to 25 minutes. So it still provides you that window to get control, to assess them, but then additional medications are needed after that. So the promise of ketamine was shown in a few pre-hospital studies and emergency department studies. None of these studies were randomized. Most of them were retrospective, but in combination, there was almost 2,000 patients between the United States, Australia, and Iran. So this was our study. Designed in 2017, started enrolling in 2018, and we'll get to some of the details in a second. So this is my clinical home. This is St. Paul's Hospital in downtown Vancouver. We're an inner-city academic hospital. We see significant numbers of patients with severe coexisting substance and mental health disorders. A good chunk of our patient population is marginally housed or unhoused. And we see about 90,000 patient visits a year. It's not the busiest in the city, but it's about number 2 or 3. So our trial, we examined ketamine 5 milligrams per kilogram IM, one-time dose, no repeat dosing, compared to midazolam 5 milligrams per kilogram and haloperidol 5 milligrams IM. Our primary outcome was time to adequate sedation as defined by the Reichman Agitation Sedation Scale score of less than or equal to -1, which for those of you that aren't comfortable with the RAS, it's essentially nonverbal yet rousable to stimulus, either voice or something like a nail bed crush or a sternal rub. Okay. Treating clinicians and outcome assessors were blinded to the intervention arm. Our target sample size was 184. We began recruiting in June 2018, and then of course, COVID. And our local research ethics board put a moratorium on in-person research as of March 17th. We watched, we waited, and after 6 months of that continued moratorium, it became painfully obvious that we weren't going to be able to appropriately restart the study, so we decided to terminate and analyze. So our primary outcomes, as I mentioned, time to sedation. But we're also very interested in the need for rescue medications, the incidence of pre-specified outcomes in terms of adverse events, both through the common reporting criteria and TROOPS. For those of you that aren't aware of this, TROOPS is a new reporting tool for sedation research. I suggest if you're doing anything related to sedation with ketamine, it's worth looking up. It's in British Journal of Anesthesia, I believe, 2017, and incidence of NMS. I hope you can all see this. We assessed for eligibility 308 patients, 227 were excluded for various reasons. The main reason patients were excluded is that they weren't agitated enough. And I'll get to that a bit later. We randomized 81 patients, 40 to the ketamine arm, 41 to the midazolam haloperidol arm, and one patient was lost to follow-up in the ketamine arm. They discontinued we didn't have data beyond the initial few minutes. We used an intention to treat analysis. I will save you the table one. It's in the publication. Our publication is free, open access. You can have a look at all the patient characteristics if you'd like. But I think this is really what you care about, is the primary outcome. Our median time to sedation for the ketamine arm was 5.8 minutes. And for the midazolam haloperidol group, it was almost 15 minutes. For those of you that have cared for severely agitated patients, you know that this is a dramatic, meaningful difference in terms of patient safety and the safety of your staff. The graph essentially shows the proportion of patients that reached adequate sedation at each time point in the trial. And you can see that there's a pretty dramatic difference within about the first 5 minutes. And throughout the entire course of the first 30 minutes of monitoring, and that's where the sedation is. Now, this is something that the editors at Annals of Emergency Medicine asked us for, and thankfully we have some very skilled statisticians working as part of our team. And what this shows really is sort of the incidence of deep sedation. They were quite concerned that we essentially snowed all the patients with the ketamine arm. They were semi-obtunded, and we were basically putting them at risk. And what this shows, pardon me, the darker blue is deep sedation, so RASS of -5, -4, -3. And you can see that for the ketamine group, they get down to adequate sedation, and the majority of them stay there, and the actual incidence of deep sedation is the same or almost less than the midazolam haloperidol group. So you get them nicely dissociated. They're a RASS of -1 or -2, but they're not so sedated that you're having to do airway maneuvers, you're having to get aggressively intervening for their safety. Now, with regards to serious adverse events, we had 1 episode of apnea in the midazolam haloperidol group, 2 in the ketamine group. 1 patient in each group required supplemental oxygen. Of note, we had 1 patient with laryngospasm in the ketamine group. They had 2 episodes of back-to-back laryngospasm within a 10-minute window. Both episodes resolved with a jaw thrust and supplemental oxygen. No further interventions were needed. And the difference was not statistically significant, yet we do acknowledge that we were underpowered with regards to safety assessment for this study. We were hopeful that with 184 patients, we'd be able to give better comment, but the joys of COVID, that was not feasible. Now, this sort of takes me to the next step about what does the future hold? We're very fortunate in that right as our study was being published, another study was published in the Western Journal of Emergency Medicine, and a study was published from Iran, also looking at ketamine but with different comparators, different control groups. And a very smart group out of New York State did this network meta-analysis looking at ketamine versus other agents for severe agitation. And in their analysis, they found that ketamine was most likely to provide you with deep, adequate sedation with a sucra of 0.93. That's essentially what the probability is of adequate sedation at 30 minutes. And this is compared to all these other sort of traditional medications which we use and don't really love. You know, even droperidol, which I hear the praises for endlessly from my Aussie and Brit colleagues, but we don't have access to. Droperidol fails against ketamine. And this was our comparison group, which sort of makes sense with our results. Now, is ketamine safer? So in their analysis, what's the probability of a serious adverse event in terms of safety? So haloperidol midazolam, fairly safe, but not as safe as ketamine. And this is a network meta-analysis looking at over 600 patients across 3 trials. So a lot to think about there. Now, to provide a bit of an add-on, our group has started working with a group out of Germany that's looking at a network meta-analysis, pardon me, not a network, individual patient data meta-analysis, so that we can really get a better granular look at the data and decide whether ketamine is the appropriate medication for severe agitation. And I think, the future, given what we know so far, head-to-head trials of ketamine and droperidol, it seems somewhat superfluous at this point. It seems like more studies for the sake of studies. And that's why I sort of lead into this next point. Is ketamine the right medication for every agitated patient? No. As most of you who work in a clinical setting will feel, verbal de-escalation, oral medications, and de-escalation of the situation should always be your first and your go-to. We don't want to have to restrain patients and sedate them, but sometimes it is necessary. But is ketamine the right medication for the severely agitated patient, especially the undifferentiated agitation that's at risk of hurting themselves or your staff? Yes. So I pose this question to you because there's a lot of people much smarter than me in this room, and I fully acknowledge that. What does the future hold for research into the severely agitated patient? Think about it. I have a few ideas which I'll share with you in a second, but I want you to take a second and think about it, because we all want what's best for our patients. We want to be able to provide better care and take care of them so that they're safe. I think that's a big thing for all of us, is patient safety. So this is something that I'm particularly interested in. A very smart group out of Yale recently published a paper that showed that in the United States, patients of Black and Hispanic origin receive restraint use at an inordinate rate compared to white patients. Sadly, I don't think this is very surprising for most of us, but it is kind of alarming. We don't have the same proportion of Black and Hispanic patients in Canada or in Vancouver for that matter, but we do have a lot of First Nations and Indigenous patients. And we're just in the process of developing and getting a study up running to look at this, because my concern is we treat them very differently. And I think if you get outside of Vancouver, if you get into some of the smaller communities where there's maybe a little bit more racism, and especially into some other provinces in the country where there's some significant issues with anti-Indigenous racism, this may be a big, big issue. So although it's not exactly ketamine, it's something to think about. It's something to think around, because you may be seeing a lot of discussion in this space in the near future around this. And then I think one of the other things for us from the emergency perspective and the pre-hospital perspective is better understanding the pre-hospital experience of these patients. We currently have a manuscript under review that shows that roughly 70% of these patients who presented to hospital for our study were either detained or restrained in some form with physical restraints by police. So yes, that is partly for their safety and for the safety of the paramedics, but it also must be an incredibly traumatizing experience for a lot of these patients. They're going through a mental health crisis or a drug-related crisis, and they feel like they're criminals. So how can we work with our pre-hospital agencies, our police, to better understand this, to better care for these patients, to possibly even de-escalate them in the community setting so that restraints, handcuffs, tasers, things like that aren't needed. Or if they are needed, it's at a dramatically lower rate. There's a lot of work to be done in this space. And I'm be the first to admit I'm not a EMS researcher, but we have a couple colleagues in my institution that are, and there's a lot of fertile ground here in terms of improving patient care. So I'd like to throw the floor open to some questions, because I'm sure there are a few for the study. And I'd like to thank you all very much for your time, your attention, and for inviting me to speak.
Fantastic. Thank you very much, David. Any questions? Yeah.
Thank you, David, for a really interesting talk, and specifically for highlighting the racial biases and restrictive practice, which is also replicated in the UK as well. I suppose in this conference we've heard quite a bit about how we don't typically give ketamine to patients with psychosis or drug-induced psychosis. And I suppose a big proportion of your patients would have those conditions. I was just wondering if you collected any data following ketamine or comparing it with haloperidol to see if their psychotic outcomes are worse, especially when we know that the longer patients are psychotic, the longer the duration of untreated psychosis, the worse their long-term outcomes are.
Great question, thank you. So just to summarize, did we collect data on the psychosis outcomes of patients that may have had underlying psychosis? So we didn't directly look at psychotic outcomes, but we looked at admission rates. And these were based off the sort of discharge summaries from the attending psychiatrists. There was no significant difference between the treatment groups. I believe the number off the top of my head, it is in the manuscript, is about 20% were admitted from each group. And their length of stays were very similar. But we didn't look at sort of specific symptom-related psychosis scores. A great question, thank you.
Back.
Sorry, just a quick process question. How do you handle the issue of informed consent in these trials?
Great question. So when we were designing the trial, we worked with our local REB to develop a waiver of informed consent. Unfortunately, a lot of emergency medicine research, whether it's cardiac arrest research or resuscitation research or agitation research like this, patients aren't capable of providing consent. And I think somewhere in the neighborhood of 95 to 98% of our patient population was certified under the Mental Health Act in British Columbia. I believe it's fairly akin to the Mental Health Act here, where essentially they don't have capacity to provide informed consent. So we worked with our local bioethicist, and they said, yes, this seems reasonable, but if a substitute decision maker becomes available, you should be approaching them. I think we had one of our 81 patients that had a care worker present with them, but a care worker in our current framework and legislation in BC can't be an SDR, or SDM, pardon me. So there were no patients that had viable SDMs. So great question.
Thank you very much for the presentation. And as a psychiatrist working in the inpatient unit, I think this is, in a way, sedation is our bread and butter. And unfortunately, we're still using this combo of haloperidol with lorazepam that often takes quite a while to kick in, but also in patients that have been resistant to have been assessed and having an ECG, clearly then raises the big question of QTC prolongation. So I have just two questions for you. One is, what about QTC prolongation in these patients? And is ketamine safe enough that you can be given even without any cardiovascular history? Point one. The other question is, again, going back to psychotic patients, have you, I know that, probably the outcome is similar, but have you ever seen any sort of explosive and flow rate psychosis after giving ketamine? Because probably that's something you would probably see straight away, because clearly that opens also the possibility of using ketamine also in patients with psychosis.
Absolutely. Great. Yeah, great questions. Thank you. So I think the two questions, just to summarize, are around cardiovascular safety and ECG and sort of emergent psychosis. So I apologize, like I said, I didn't put up the table 1 from the study because I know the results are primarily what people want to see, but it is there. And if you just look it up, it is free and open access, the paper. The ECGs were similar between the midazolam, haloperidol, and ketamine groups, and there was no evidence of QTC prolongation for either group. These patients, at least in our department, they come in, we're very fortunate. We have a very large, experienced security detail, and we very often have police bringing these patients in, but they're still not ready to have an ECG done. So they get put in restraints and simultaneously get sedation, and then 5, 7, 10, 12 minutes later, they get their ECG. They get their labs pulled. If necessary, they get CT imaging of their brain, they get x-rays and that kind of thing. So the ECGs all happen 5-10 minutes after the sedation is administered for the safety of the ECG techs. And there are no significant changes. The only things we saw was sinus tachycardia, no QTC prolongation. With regards to the emergent psychosis, we looked at Health Canada asked us for a visual analog scale of emergence reactions. There was no significant difference between the groups. We didn't see sort of a true psychosis, but I would qualify that with saying the number one mistake that I see when people give ketamine for severe agitation is they don't give enough. The giving 2 milligrams, 3 milligrams per kilogram leads you to a partially dissociated, screaming, terrified patient. If you want to gain appropriate control so you can take care of the patient, it's 5 milligrams per kilogram. All the other studies have said 4 to 5 milligrams. Underdosing is where you get that screaming, dissociated, upset patient that's terrified. They don't know what's going on. And that's what I would say is probably what I think you're referring to. So.
A question. Oh, yeah. Okay.
Are there any difference in the duration of the sedation in the ketamine and the agitation?
Yeah, so that was almost impossible to answer. The reason that was the case, Health Canada insisted, so in Canada, you have to go through Health Canada to do any drug trial. They have to sign off on stuff in your protocols. And Health Canada insisted that treating clinicians still have the discretion to provide rescue medications if they felt the patient was under sedated. They didn't want patients put at risk. And so there was no difference between the treatment groups, but a large chunk of patients received rescue sedations at 25, 30 minutes. So to know exactly the duration of sedation between the two groups when you have that complicating factor, it was almost impossible in our analysis. So, but great question. Thank you so much.
Thank you very much, David.